Hello, my name is DeNaeyer, and for this lecture I want to discuss with you how we can use scleral lenses to help successfully manage patients with ocular surface disease. For some of the objectives for today's lecture include discussing exactly what ocular surface disease is and some of the steps that we might employ to manage this disease process, as well as, of course, the role that scleral lenses may play. We'll go through some case examples that will highlight some key points of our discussion. I will talk a little bit at the end about soft contact lenses and what role they may play for certain candidates, as well as touch upon neuropathic pain. What exactly is ocular surface disease? Ocular surface disease is a disease process that can significantly affect the lids, conjunctiva, and the cornea of our patients. The etiology is mostly from dry eye disease, and not just mild dry eye disease, but very severe dry eye disease. Systemic disease can also play a role, as you will see throughout this lecture. What are the characteristics of ocular surface disease? Well, typically it is bilateral, but we do have patients that can be asymmetric, where one eye is affected more than the other. It can be quite variable, so we can have patients with mild ocular surface disease that's almost subclinical, and then on the other end of that spectrum we may have patients who have very severe ocular surface disease, and in fact severe enough that it leads to disability. Well, when we look at dry eye, we can go back to the dry eye workshop, and basically they have categorized dryness into either evaporative dry eye or aqueous deficient dry eye, or a combination of both. And I think what we typically see for our mild dry eye patients that we don't really consider to have ocular surface disease, most of those patients are going to be evaporative dry eye. For the patients that develop ocular surface disease, where their dryness is either moderate or more severe, and these are the patients that we may be dealing with as far as therapeutic contact lenses, many of those patients will at least in part have an aqueous deficient component. And aqueous deficiency is often the result of systemic disease, including graft versus host disease or Sjogren's syndrome. So those disease processes affect the lacrimal gland, and those patients essentially produce less tears because of that. Other systemic diseases can actually cause complications to the conjunctiva, and of course the conjunctiva contains the important goblet cells that are needed to maintain normal ocular health. So some of those disease processes that can contribute in a way to ocular surface disease by affecting the conjunctiva include ocular cicatricial pemphigoid or Stevens-Johnson syndrome. Well, how does ocular surface disease affect the lids? Well, it can cause trichiasis, dystichiasis. It can result in entropion or extropion, or the patient can develop an reactive ptosis, a way that they're trying to close their eyelid in order to protect themselves. As far as the conjunctiva, ocular surface disease is an inflammatory process, and so it can result in significant injection, fibrosis to this tissue, and in some cases symblepharon, which is an adhesion between the palpebral and bulbar conjunctivas. What about the cornea? Well, the cornea probably is one of the most important tissues that we're going to deal with because it gives the most symptoms. But if we look at the patient under examination using the microscope, what we're going to see is typically a patient who has keratitis. They can certainly have punctate erosions, vascularization, and all of that, of course, can lead to scarring. Now, as far as symptoms that are related to the cornea from ocular surface disease, these patients will complain of dryness, pain, photophobia, reduced vision, and in my estimation, reduced vision is often an overlooked symptom from the patient, where I think we're all trying to make the patient more comfortable with either drops or palliative care, scleral lenses. But in fact, many of these patients don't see well, and that's because they have a disrupted tear layer, or again, they have significant erosions of their cornea. Well, looking at how we might manage patients with ocular surface disease, we can go back to our DEWS report, our dry eye workshop report, and they have recommendations for a stepwise management a system that will allow you to help these patients. And step one, and this is the start of how we might manage these patients, that includes lubricating drops and ointment as well as lid hygiene. Step two then, this is again for patients who haven't been helped by the first step, and so they might be a little more moderate or severe. These patients will start to we start to categorize them as having ocular surface disease. They might have punctal occlusion or oral or topical pharmaceuticals. And then step three, this is again the patient hasn't been helped at least fully by step one and step two. Step three is a more severe patient. We might prescribe autologous serum for the patient. And of course, this is where we get and are ready to employ therapeutic contact lenses, which include soft contact lenses as well as scleral contact lenses. And for me, in my mind, this step using lenses hopefully will be successful enough that we can avoid step four, which often involves some surgery. Well, when we look at scleral contact lenses, looking at the SCOPE study, the survey study, we find, I think what we have already sort of, what is known and well established is that most practitioners are using scleral contact lenses to manage patients with ocular surface disease. But there is a very important niche in place for scleral lenses for patients who have ocular surface disease. This is kind of an interesting set of results from the SCOPE study on the role of scleral lenses in the treatment of ocular surface disease. And what they found is that scleral lenses were considered a first, second, or third option by 21% of respondents, and as a fourth, fifth, or sixth option by 52% of respondents. So practitioners that are fitting scleral contact lenses are using scleral lenses to help manage these patients. Well, what do scleral lenses, how do scleral lenses help patients with ocular surface disease? Well, they provide three things. One, protection. Number two, the fluid reservoir. And number three, improved vision. So I want to go through each of those separately. We talked about the lids. Lids can have trichiasis, dystichiasis. The lids can have keratization. All of that can cause mechanical trauma to the ocular surface. Scleral lenses help protect the lid from this trauma. Then we had the fluid reservoir, the reservoir of fluid that's trapped between the back of the contact lens and the cornea. And that fluid reservoir acts to help hydrate the corneal surface as the patient wears the lens during the day. And I'll be able to show you with some case examples some dramatic changes in corneal health after patients have worn scleral lenses for a couple of months.
Miru 1 month delivers one of the highest levels of oxygen transmission. Available in sphere, toric and multifocal. Miru 1 month contact lenses from Menicon.
And then finally, as we've mentioned, vision. So punctate erosions can create irregularity that ultimately decrease the best corrected visual acuity for these patients, and scleral lenses can help improve their visual results. And again, we'll go through some case examples of that. Now, when we talk about fitting scleral contact lenses for patients with ocular surface disease, we may want to look at some specifics that may differ or be the same as how we may design and fit a scleral lens for a patient, for example, with keratoconus. And the first parameter that we'll look at here is diameter. And I think the thought process might be that bigger is better, so we might fit a larger scleral lens to cover every square millimeter of the anterior ocular surface. But in my experience, I typically will use a lens that is a standard diameter size, much like I would use for corneal regularity. So somewhere between 16 and 18 millimeters of diameter. And I've been very successful with that. We may want to consider larger diameters if the patient's conjunctiva is more severely affected. Or we may use the lens as in part as a conformer to prevent adhesions between the palpebral and bulbar conjunctiva in cases of patients, for example, with ocular cicatricial pemphigoid. Sometimes we may consider smaller diameters if the patient has a smaller cornea, or they have smaller apertures where they may have difficulty with applying the scleral contact lens. And then what about the fluid reservoir? I think, again, our hypothesis might be for someone who is severely dry that more is better, so we want to give the patient more reservoir fluid. But interestingly enough, there was a paper published in Optometry and Vision Science by Sansino and Matthey, and what they showed was that successful patients, ocular surface disease, dry patients using scleral lenses, they were successful independent of the fluid reservoir volume. And so I think in my practice, I try to maintain this sort of normal set value for all my patients, which is a fluid reservoir of between 100 to 200 microns. We want to be careful about going less than 100 microns because of potential long-term settling, and we don't want these lenses to eventually settle and bear onto the corneal surface, which is already compromised. And then we want to be careful about going more than 200 microns because that, of course, decreases transmissibility or oxygen to the cornea. What about filling the scleral contact lenses with solution? This is super important for this patient subgroup. Most practitioners prescribe 0.9% sodium chloride saline solution. In the United States, there's off-label and on-label versions of this. Most importantly, we just want to keep everything non-preserved because we don't want to introduce a preservative that could basically develop a toxicity or hypersensitivity, again, especially for a patient's surface that is already compromised. We want to avoid boric acids for this patient population because boric acid has been shown to be toxic to the epithelium, and these patients probably have a hard time dealing with that buffer, that preservative. And then I just wanted to point out Condimac has a relatively new filling agent or solution called Neutrophil, and this is quite unique. It has 5 electrolytes in its composition, and its osmolarity and pH have been formulated in such a way that it mimics the natural tears. So something very excited for all of us to try. Well, some complications that we can see with patients with ocular surface disease who might wear scleral contact lenses include midday fogging, and any scleral lens patient can have this problem. Basically, midday fogging is where we have debris build up within the reservoir of the scleral contact lens. In my experience, this is a bit more common with patients with ocular surface disease because they produce more mucus, and that mucus can get sucked up underneath the contact lens. Ultimately, midday fogging can affect vision, causing the patient to have to take out the lens and rinse and refill it during the day. Some tips that we may employ to reduce midday fogging. Number one, make sure that you properly align the landing zone of the scleral lens to the bulbar conjunctiva. If we have gaps between the contact lens and the scleral surface, those are entrance ports for debris to get underneath them and into the reservoir. Decrease the overall corneal vault or fluid reservoir. Lowering that does help patients' symptoms. And then we could add a solution to the bowl of the contact lens with some increased viscosity. That does slow turnover and does help some patients. It's remarkable. So something like hydroxymethylcellulose might be something, again, in the United States that's off-label, but something you can try. Well, wetting can be a problem for any scleral lens patient, but certainly for a patient in this category, patients with essentially a severe dry eye. And this can be problematic because it can certainly affect their vision and comfort during lens wear. So we want to treat the surface of the contact lens. I always have every one of my lenses plasma treated. That's an ionic process that basically super cleans the front surface or the surfaces of the scleral lens and does help with wetting. The other, again, relatively new addition is HydroPeg by Tangible Science. This is a liquid coating that can be applied to the surface of the contact lens to help it to wet better. And we can go through a case example where I've used HydroPeg to help a particular patient. This is a patient of mine with graft versus host disease. We ordered her a scleral contact lens that only had plasma treatment, and when we applied the contact lens for the first time, the lens wasn't wetting really at all, as you can see from this photograph. In fact, her best corrected visual acuity because of the non-wetting was only 20/50. So I had the manufacturer design another lens, this time add tangible hydropeg. And once we applied the lens now, the lens wets perfectly. In fact, this improved her vision to 20/30. Now, one potential issue with hydropeg is that we don't know how long it lasts, maybe 3 to 6 months. But it may be enough just to get the patient started. And something else to remember as well is that some patients actually don't like hydropeg. So I've had patients where they've not had hydropeg, have done fine with scleral lenses, and then we've reordered them a new lens, replacement lens, after 2 or 3 years, and we've added hydropeg because they have ocular surface disease. So thinking this may help the patient, but in fact, actually, some patients don't like it, and they've complained about their vision.
Un comprobado líder en la práctica de lentes especiales y ojo seco. Cuando la precisión importa.
With that surface treatment. Well, patients who non-wet or have poor wetting to the scleral contact lenses are more prone to deposits, and those deposits, of course, can affect vision and comfort, so we have to be careful of those. And if those do develop, then we may have to add an extra strength cleaner to our regimen. Keep in mind that those extra strength cleaners will take the hydropeg surface off, but if they're depositing material onto the contact lens, that's something that you're going to have to do. Well, let's go through some case examples, and again, we're going to highlight some of the discussion points that we've already went through for the lecture. First patient is a patient with Sjogren's syndrome. She's a 65-year-old female patient who had a flare-up in her left eye, actually left eye greater than the right eye, and this was a couple years ago. She developed in her left eye significant punctate erosions, which caused her to be very uncomfortable, reduced her vision. So she was referred to me from her treating ophthalmologist. She was using Refresh and Retain drops as well as fish oil supplements. This is her best corrected visual acuity with manifest refraction of her left eye, and you can see that she's only seen 2200, so not very good. Well, we of course consider scleral contact lenses for the patient, and those scleral contact lenses can provide the patient protection, a continuous liquid reservoir, and hopefully also improved vision. And my first step in the fitting process is to do corneal scleral topography. And after that assessment, as it turns out, both of our eyes had significant scleral asymmetry, so we fit her with free-form, highly customized scleral lenses from corneal scleral topography. Those lenses were 16.5 millimeters, and with the first lenses, we were able to be successful with lenses that had adequate reservoir, fluid, perfect landing zone alignment. We did prescribe hydrogen peroxide and off-label use of 0.9% sodium chloride saline solution to fill the bowl of the lens. And this patient, with the lens on her eye, on her left eye, she improved to 20/20, so quite a dramatic result, and the patient was thrilled. This was her cornea before with those severe punctate erosions. Again, she's only best corrected to 2200 at this point. And then this is her cornea after 2 months of scleral lens wear, and we can see complete resolution of her punctate erosion. So quite a dramatic turnaround, and again, her vision's 20/20. Some key points for her case: therapeutic modifications. Basically, we're co-managing this patient with her ophthalmologist, so she continues her Refresh and Retain drops. And of course, even though her cornea is significantly improved in her left eye, she continues her scleral lenses. So she's going to benefit from those, and if she has any more flare-ups or problems, the scleral lenses will help to keep her cornea healthy and her vision sharp. All right, second case is a case with ocular surface disease, 70-year-old male patient, and this is kind of a unique case because only his left eye was affected, and this is a photograph of his left eye, and you can see that he has severe corneal erosions. His right eye had no problem at all. So this is a very unilateral case, and No etiology for this, no diagnosis. He was managed by an ophthalmologist. Best corrected visual acuity in his left eye was 2300. He was using refresh up to 4 times a day, restasis, and had punctal occlusion, but really wasn't getting better. And so the ophthalmologist, number one, considered a tarsorrhaphy, so to basically sewing the lids closed together to help protect the surface, but also scleral lenses. And so he was referred to me for a scleral lens fitting for his left eye. So like the last patient, we do corneal topography, corneal scleral topography. And like the last patient, his sclera happens to be fairly asymmetric. And in fact, virtual fitting software shows that a symmetric fitting design isn't going to land evenly or well on his bulbar conjunctival scleral tissue. So for him, we did do a free-form customized scleral lens that was designed from corneal scleral topography. And that lens fit very well. He did well. His vision improved to 20/30. And he, like the last patient, was thrilled really immediately with the success of the scleral contact lens. So this is his before cornea. This is the left eye. Best corrected glasses vision is 2300. And then to the right, after several months of scleral lens where he has complete resolution of his punctate erosions. And with glasses, he's 20/60. Now he does still have some irregularity, and you can see that there's a persistent scar there that's paracentral. But all the erosions are healed, and with the scleral lens, he was 20/30. So very much a success for this patient. Key points, this patient was actually turned over to me for my care from that ophthalmologist. I actually stopped his restasis because it really wasn't helping him, and he continues to refresh drops pretty much as needed, but he, of course, continues to wear the scleral contact lens quite successfully. Next patient is a patient, an 83-year-old female patient with ocular cicatricial pemphigoid. This patient was being managed by 2 different ophthalmologists using autologous serum tears, polymyxin, and her left eye. And interestingly enough, she had an allergy to restasis and Zedra. She has very small apertures, so that's going to be an important point as we consider lens design for scleral contact lenses. Her best corrected visual acuity was 20/40 in the right eye and 20/80 in the left eye. On top of all that, she had glaucoma and had filtering surgery, and that resulted in significant superior bulbar conjunctival blebs there that we're going to have to deal with the scleral contact lens. With that, with lens design, I decided to decrease the diameter to ease the process of successfully applying these scleral contact lenses. And we did go with a highly customized lens, mostly because we needed the lens landing zone to vault over her blebs that are the result from her glaucoma surgery. So here's the result here. Very nice fitting lenses with adequate reservoir, alignment of the landing zone, including the blebs. We prescribed her peroxide care system and off-label 0.9% sodium chloride solution. She continues her medical therapy and is also followed by her ophthalmologist, so basically co-managing that patient. And you might think that these lenses really act as a conformer too. Remember, she has ocular pemphigoid, so we worry about those symblephrons. Her vision is 20/30 in the right eye and 20/25 in the left eye. One update though, and this kind of just shows you that not everything's perfect. She moved away, and then we recently got a phone call that she was having trouble with the right lens, and it was just never felt comfortable to her. And then on top of that, her new ophthalmologist has discovered that her glaucoma, her eye pressure has continued to rise despite her successful bleb. So she has discontinued the right scleral lens, at least for now. She wears the left one without incident or problem. And then if perhaps she is able to make it back to her office and she has her glaucoma under better control, then we can reconsider contact lenses for her. ophthalmologist, a cornea specialist. So she's been taking Restasis, autologous serum, and Sustain. She's had punctate occlusion, previous management of her meibomian glands, and previous steroid treatment. But still having trouble, so she was sent to me for scleral lens fitting. I did fit her with 16.5 millimeter scleral lenses. Her visual acuity with the lenses was 20/25. Very nicely fit, landing zones aligned. She continues her medical therapy with her other ophthalmologist. So again, this is more of a co-management situation. But one thing I wanted to bring up with this patient is that she also has arthritis, and that caused her to have trouble applying the lenses successfully. So for her, we implemented a lighted stand that she can use for application. So I'll show you that video here. And I'll tell you for certain this was the difference between success and failure. So this allows her to successfully put the contact lens in. She lowers her eye right onto the lens surface there. She's going to feel a little liquid first, and then she's going to continue to press on there. Eventually let go of her lids, and then sit upright, and voila, she has the lens on. So very nice. And I will definitely say that I will prescribe and utilize a lighted stand for scleral lens application probably one time a week. And again, it can be the difference between success and failure. Well, what about soft contact lenses? I mean, I think that generally soft contact lenses are the antithesis because generally we think of soft lenses causing dryness, but they can help protect some patients with ocular surface disease. We want to consider whether the patient would wear them on a daily wear basis, taking them out at night, or more of a continuous wear, extended wear basis. We want to stay with silicone hydrogel materials, give the patient the most breathable type of polymer. I just want to go through a case example of mine where we utilize soft lenses. This is an 85-year-old female patient with ocular cicatricial pemphigoid, very severe, severe discomfort for this patient. And she's on Restasis twice a day in both eyes, artificial tears. Her best corrected vision is not good, 2400 in her right eye and hand motion in her left eye. She's got significant corneal erosions. Her lids have matarosis and trichiasis. And this patient is elderly and quite disabled, and there was just no way that she was going to ever be able to successfully apply a scleral lens, even with help with a family member or aid. So instead, what we did was we fit her with continuous wear or extended wear, FDA-approved silicone hydrogel lenses, and that significantly helped her. She would come into the office about every 2 weeks, and I would remove and reapply new contact lenses for her, and that actually worked quite successfully for her for about a year. She was very satisfied. Unfortunately, she developed symblepharon, and enough symblepharon that her eyelids, her lids, I couldn't make enough space to successfully apply the soft contact lenses anymore. So we had to discontinue that, and now she's back to her ophthalmologist under their care. Hopefully at some point in time we might be able to restart that, depending on the situation with her symblepharon. Well, one last item, and that's neuropathic pain. Neuropathic pain is either a peripheral sensitization, those are the nerves that go just out into the corneal, or central sensitization, so a sensitization of nerves of the central nervous system. And this can happen after trauma, LASIK surgery, dry eye disease, or Sjogren's syndrome. Essentially, these patients are super sensitive to a stimulus. And what's sometimes a challenge is that you may find a patient that their eye actually looks pretty healthy, but they describe severe irritation and discomfort. And this is where we may get the moniker pain without stain. So if you see that type of presentation, you might want to think about neuropathic pain. There's some way to diagnose it, I should say. It's really a diagnosis of exclusion. Sometimes we can use confocal microscopy to look for inflamed nerves. We can do a proparacaine challenge to try to differentiate between peripheral and central sensitization. But one reason I bring this up is that you may be doing everything correct to help manage a patient. The scleral lenses may work great, but the patient still is having a lot of trouble. So keep this on your list, on your differential list, because the patient actually can sometimes be so sensitive that a scleral lens will make them worse, because again, they're oversensitive to touch because of their hyperalgesia. And if you suspect this is the case, then the best thing to do is refer this out to an expert, and potentially the patient may need some oral pharmaceuticals for management. Well, just to conclude, scleral lenses for ocular surface disease, they are just one component in an overall management strategy for this patient population. When we're fitting them, two most important steps: make sure you have enough fluid reservoirs so the lens isn't bearing on the cornea, and really try to make the landing zone as evenly as possible across the surface. Speaking of the front surface, we want to keep that clean and as wettable as possible. We want to employ application aids as necessary, so those lighted stands can make a big difference. And occasionally we may need to use soft contact lenses. I want to thank you very much for your time. My email's there. Please email me any questions or comments. Thank you.